Hi guys. So we only have Monday left before the final, and I thought that I could finish lecture, or at least go over nursing management of emergencies and disasters, because I don't know if we're gonna have enough time um, on Monday, because we only have like 2 hours, and I would rather it be a review than give like all new information and then you guys only have one night to study. So, um, we left off on sepsis. So, let me get that PowerPoint. Okay. What happened? All right. So, sepsis. Sepsis is one of the most important types of shock um, that as a nurse you need to be able to recognize. Okay. So, sepsis is severe and systemic response to an infection that can lead to decreased tissue perfusion and organ damage. So, we have really honestly cardinal signs. Your patient is most likely going to be febrile. They are going to have some type of signs of infection. So, say you have sepsis from pneumonia, they're going to be symptomatic of pneumonia. They have sepsis from cellulitis, they're going to have a cellulitis rash. They're going to have warmth, redness, pain. And say they have sepsis from a UTI, they're going to have symptoms of a UTI before it, kind of progresses to sepsis. The next step within sepsis is mental decline. The infection just kind of takes over, and that clarity just kind of goes right out the window. And then the patient is extremely ill. Like they just look bad, they feel bad. You walk in the room and you're like, oh my God, this person is really, really sick. So you have 3 stages of sepsis. The first stage stands for systemic inflammatory response syndrome. So this is any of these symptoms where you meet 2 or more criteria. So the criteria is a temperature greater than 100.4 or less than 96.8, a respiratory rate greater than 20, heart rate greater than 90, because remember, sepsis is like hand in hand tachycardia, okay? And a white blood cell count of either greater than 12,000 or less than 4,000. Stage 2 is where you actually hit sepsis. So this is 2 or more signs of SIRS, and then also a confirmed or suspected infection. So this is UTI confirmed by urine culture plus 2 or more of those hallmark signs or criteria, right? And then step 3 is going to be septic shock. Septic shock is included in the disruptive shocks. So this is where also you're going to see massive vasodilation. It is a systemic inflammatory response due to an infectious source. So your causes are going to be indwelling devices such as central lines, like Foley catheters, endotracheal tubes, or a trach. This is why we have such a movement in the hospital to decrease CAUTIs, CLABSIs, VAP, the ventilator associated pneumonia, because these indwelling devices are such a high indicator or cause for sepsis. So then you also obviously have regular infections like a UTI, wounds, pneumonia, and then you could have sepsis from an invasive procedure like a surgical procedure, and then if your patient is immune compromised. So, if your patient is on long term steroid use, if your patient is on antivirals, if autoimmune drugs, okay, all of those drugs that cause immunocompensation compromise are going to put a patient at higher risk for septic shock. So, it's important to know that there's early stages and late stages of sepsis. So early, you are hypertensive, tachycardic, increased respiratory rate. Your cardiac output is high, but you have that vasodilation that is eventually going to lead to hypotension. Okay, so this is when your vasodilation is just kind of getting started. Warm and flushed skin and hyperthermia because you're febrile. Your late stages, that vasodilation is in full gear, okay? The blood pressure is tanking, your heart rate is high because it's trying to compensate for that decreased blood pressure. Your oxygen saturation is low because your cardiac output can't keep up because your blood pressure is so low, right? Just like all the other disruptive shocks that we just talked about. Your skin is cool and clammy. Sometimes your patient can look mottled or even have like just a palish, grayish hue. Decreased urine output because there is no perfusion to the kidneys. And you have an altered level of consciousness, which will eventually lead to coma. So for treatment, you have your broad spectrum antibiotics. You guys, I hope that you guys learned this a very long time ago. You should always get blood cultures before you start antibiotics. But, huge but, if you have a patient that is really ill and very symptomatic, you really don't want to delay care. Say you've run out of blood culture tubes and the lab is going to take 3 hours to get you blood culture tubes. Are you going to really wait to give broad spectrum antibiotics to hopefully decrease the risk of septic shock and wait for blood culture tubes to arrive? No, absolutely not. Blood culture tubes are not important enough for your patient to possibly lose their life because you needed to wait. And then you want to increase tissue perfusion by giving fluids. Part of the sepsis protocol is giving a lot of your isotonic fluids, which is obviously your normal saline and your LR. Most of the time, if your patients are truly in septic shock, they're most likely going to need vasopressors. And this is going to be your norepinephrine, neosynephrine, vasopressin, and epinephrine. I put all of those drugs on your common critical care drugs. So you should have filled that out. You should be a little bit more versed on what those are. And then we've talked about this throughout, I think, every type of shock is prevention of stress ulcers. So you want PPIs, you want H2 blockers, you want early nutrition, which is most likely going to be in the form of tube feed. And then you wanted to monitor those lactate levels, because lactic acidosis, the higher the lactate goes, the more acidic you are, the sicker you are. So then we have stage 4, which goes into what we call MODS. MODS is multiple organ dysfunction syndrome. So this is severe sepsis with multiple organ system failure. Okay. Your organs have not been perfusing. They're not getting enough oxygenation. The infection has just kind of taken over, and the severity of the sepsis and shock have caused other organs to start shutting down. So this is where your kidneys start shutting down. This is where your liver starts shutting down. Your lungs are shutting down. We talked about MAP the other day. MAP is your mean arterial pressure. You always want to, and this is where your titrating of pressors comes in, because when your patient is in shock, it is so important to maintain a MAP of greater than 65, because if your patient has a MAP of less than 65, their organs are not perfusing. Their brain, their lungs, their heart, their kidneys, their bowels. My kid is laughing. They are not perfusing if that MAP is less than 65. So a lactate, you want a lactate less than 4 after fluids. Hopefully that's what happens. You want your lactic acid to go down. Respiratory failure is bound to occur at this point, because everything is just failing. And altered mental status, your brain is not perfusing. The infection is taking over. You have metabolic acidosis at this point from increased lactic. And this is where people have a really hard time coming back from. So we have a case study with sepsis. Mr. McMillan is a 92-year-old male and presents to the ED with urinary hesitancy and burning and a fever at home of 101.6. His caregiver states that he just doesn't seem like himself. So immediately, I want you to start thinking, this patient is 92 years old. The elderly population, one of their first signs of a UTI is confusion, and his caregiver is telling you he's not himself, right? So what initial nursing assessments need to be performed? You guys know, first of all, the first thing you guys always say is vital signs. Yes, 100% we need vital signs, okay? Old carts, or the PQRST, the pain assessment. And this is going to be probably linked more to his urinary symptoms. And then, of course, a neuro assessment with level of consciousness and orientation is going to be really important. Heart and lung sounds. We need to, assess a baseline of what's going on. Where is his respiratory status? What's going on with his cardiac output? What does his telemonitor look like? So we want to make sure we assess all of those things. So upon further assessment, Mr. McMillan is weak. His face is flushed. His skin is warm and dry. He is oriented to person and place, but states that the year is 1952. His vital signs are 99/60, heart rate 92 and regular. Respiratory rate is 28 with a oxygen saturation of 93% on room air. We have a temperature of 98 or I'm sorry, 38.9. And then they give us his height and weight. So physiologically, what is happening? This is our first step into sepsis recognition, right? Um, so any two positive symptoms of the SIRS criteria, have we met those, right? So look back at that SIRS criteria and does he have an elevated temperature? Yes. His temp is 38.9. Does he have an increased respiratory rate? Yes, his respiratory rate is 28. Does he have an increased heart rate? Is he severely tachycardic? No. Is his heart rate greater than 90? Yes, it's 92. White blood cell count? I don't know. I don't have labs yet. Hopefully we've already sent them. Are they greater than 12,000 or are they less than 4,000? I don't know yet. We'll see. But with the temperature, respiratory rate, and heart rate, he is absolutely positive for SIRS as of in this moment. Okay. So, what nursing intervention should the nurse perform for Mr. McMillan? So, he's on room air and he's 93%. So, we need to increase his oxygenation, right? So, maybe we could put him on a nasal cannula, raise the head of the bed. We already talked about Telly. I would absolutely apply a cardiac monitor, not only because of his age, but because of the situation and possible impending sepsis. Of course, we're going to notify the provider of our increased temperature and SpO2 in order to kind of help cool him down, because the elderly population have a difficult time with thermoregulation, right? So we could help with cool washcloths or like on his head or neck. If his temperature was even higher and it was getting into like a dangerous zone of like 103, 104, hopefully not 105, but you could do ice packs under the arms, between the legs, on the chest, abdomen. This really helps cool people down in those areas. And then take his blankets off. I mean, that's just an easy fix. Take the blankets off. So our provider has ordered a CBC, BMP, ABG, a lactic, blood cultures times 2, a urinalysis, urine culture, chest x-ray, KUB, which is an x-ray of the kidneys, ureters, and bladder. Usually involves a lot of the abdomen too, so you'll get to see if there's anything crazy going on with the bowels, bowel loops, if the patient is constipated. You can see stuff like that on the KUB. Nasal cannula to keep the oxygen saturation greater than 92%. And then we want a bolus of normal saline, at least a liter for now, and some broad spectrum antibiotics. He ordered 1,500 milligrams of vancomycin IV piggyback times 1 dose. So, where should we go first? What do you think? So last we saw, his oxygen saturation was 93% on room air. So I know immediately your brain wants to go to airway, but as of right now, he is protecting his airway and his saturations are 93%. So we're not going to pick nasal cannula first. What can we do right this very second? Chest x-ray is ordered, KUB is ordered. We need to wait for x-ray to get there, right? We don't take x-rays. So the order is in, x-ray is going to come. The only thing that we have, and we have to, if we don't have Vanc in our Omnicell, we probably have to wait for our pharmacy to come give it to us or send it to us. So what can we do right this very moment? Well, I need an IV, right? We don't know if this patient has an IV. So as soon as we get an IV, at the same time, we can get our CBC, BMP, ABG, lactic acid, and we can get at least our first set of blood cultures. So why does it say blood cultures times 2? Blood cultures should always be drawn in sets of 2. And remember, talking about blood cultures, we have aerobic and anaerobic. So blood cultures has one set has 2 bottles, one is aerobic, one is anaerobic. But you want to have 2 sets, okay? And they have to be drawn by 2 separate blood draws. So if you get this first blood culture off of the IV that you just started, you will have to do another venipuncture from somewhere else, usually the other extremity, to get the second set of blood cultures. And then we can get our urinalysis, urine culture, and then for me next, I mean the right answer is going to be you have saline right there. As soon as you get all of these labs and blood cultures, boom, immediately you're going to hook up your saline bolus, okay? And then at that point, we're really going to be searching for those antibiotics. Where are the antibiotics? I need to get these going. I need to get these in. So realistically, if this was your patient, all of these things on this list should be completed within 30 minutes. Maybe minus the chest x-ray and the KUB depending on radiology. But 30 to 60 minutes for sure. If anything is taking longer than that time, I would start making some phone calls. So all blood and urine tests are completed and you initiate the fluid bolus for Mr. McMillan. You are still waiting for the Vanc to arrive from the pharmacy. You notice he is more drowsy. He is now only oriented to self and he feels warmer. He was already 102 point something degrees and now he feels warmer. So you take another set of vitals. Blood pressure is 86/50. He is becoming more hypotensive with that vasodilation. His MAP is 62. What does that mean? That means that he is not perfusing. His brain is not perfusing adequately. His organs are not perfusing adequately. His heart rate is 108. His temperature is 39.3. Respiratory rate is 36 and he's 88% on room air. Trouble. We are in trouble. We are in impending trouble situation. Okay. Mr. McMillan's lab results have also come back. We have a white blood cell count of 22,000. Lactic is 3.6. pH is 7.22. CO2 is 30. Bicarb is 16. PaO2 is 64. Our urine is cloudy with sediment and blood cultures have confirmed infection. Now, blood cultures usually take a couple days to come back. So, and we know from this case study, it hasn't been a couple days. We're still in the ER. So, in the real world, those blood cultures aren't coming back that fast. But urine, though, being able to see the sediment and the cloudiness in the urine is definitely a very indicating sign. And that urinalysis is going to show something pretty quickly. So we are now meeting about all of the criteria for sepsis at this point. So what actions are we taking? Number one, now at this point, because he is more symptomatic, what comes first? Airway, breathing, circulation. So number one, we need a nasal cannula. We need to get this patient oxygenated, okay? Also, when we're looking at the gas, let's go back. What is happening here? Our pH is very acidic. Our CO2 is pretty acidic. And our bicarb is also acidic. So at this point, there is absolutely no compensation. There is nothing's happening here. And he is in complete metabolic acidosis at this point because of that lactic acid. So, what stage of sepsis are we in? I pretty much already gave you that answer. This patient is in stage 2 of active sepsis. Okay. What orders do you anticipate for Mr. McMillan? Any procedures, meds, transfer, etc.? So, what do you think is another thing that we're going to be doing for him? What did I say was sepsis protocol? We already gave a liter of fluids of normal saline. Would you expect, if it's not contraindicated, for this patient to receive more fluids? If his chest sounded clear, if he had no signs of pulmonary congestion or edema or even peripheral edema, absolutely I would anticipate more fluids. I would also, the guidelines for patients with fluids for sepsis should be to receive 30 milliliters per kilogram of body weight in the first 6 hours of sepsis. So for this specific patient, he would need at least 1,800 milliliters of fluid boluses. So we already gave him 1 liter. At this point, we would definitely expect to give him that second liter. Also, his MAP is 62. At this point, he's just getting sicker, and we probably need to get some vasopressors because we need to start perfusing his organs and his brain. So we don't prematurely go to mods because nothing is perfusing. Okay. Also, we're thinking, I mean, this patient is critical at this point. We have impending septic shock. This patient is quickly becoming critical. And then we need to really start thinking about critical access. Do I need a central line? If you are running vasopressors and you are bolusing a lot of fluid and you're giving a lot of antibiotics, a lot of things are happening, you should probably anticipate getting a central line. Also, if your patient is going into septic shock and you are getting on vasopressors, I would absolutely ask for an arterial line so that I can monitor closely what is happening with my patient. And then, of course, this patient obviously needs to be transferred to the ICU. Regular step-down units cannot take a patient on pressors. So, Mr. McMillan responds well to the first liter of fluids. His antibiotics are initiated within an hour of arrival, which is so good. The ED physician places an ART line and a central line to initiate vasopressors. I love that. They order norepinephrine, aka Levophed, infusion to be titrated to keep MAP above 65. The critical care team asks you to prepare the patient for transfer. So your ART line states that he is 82/48. His MAP is 58. His heart rate is 122. His CVP, which is a central venous pressure, is 4. Respiratory rate is 32. His systemic vascular resistance is 640. And his PaO2 is 90% on room air. He is showing signs of decreased perfusion to his brain with decreased level of consciousness, and he is showing decreased cardiac output with that hypotension. He is warm and flushed, and his temperature is elevated because of the vasodilation in the non-vital organs. This guy is going down really quickly, okay? Really quickly. At this point, we have impending respiratory failure, okay? So what does it mean to titrate an infusion to keep the MAP above 65? I've mentioned this multiple times at this point. MAP is your mean arterial pressure. Every time you take a blood pressure, you have a systolic pressure, you have a diastolic pressure. Right next to those numbers, you have this little itty bitty number, and it is imperative that we keep that number greater than 65. Why? 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 Because if that MAP is not greater than 65, we have decreased tissue perfusion. We have decreased oxygenation to the brain, to our lungs, to our heart, to our kidneys, to our liver, to our digestive system, to your extremities, to your fingers, to your toes. Everywhere in your body is not perfusing adequately. Okay? After 2 days in the ICU, a norepinephrine infusion, and a total of 2 liters of normal saline, Mr. McMillan's blood pressure is stable. His MAP is 67. He is becoming more alert and is now oriented to person, place, and time. His blood and urine cultures were positive for bacterial growth. He has received multiple doses of vancomycin as well as antibiotics targeted to his specific bacterial infection. He's being weaned off of vasopressors, and the providers hope he can transfer out of the ICU tomorrow. What explanation or education topics would you want to provide to the patient and his caregiver before discharge? What are we thinking? I want to give you time because I want you to kind of think through this before I just give you the answer. Because obviously in class, I would want you guys to talk to me. So, sepsis and septic shock are a result of a severe infection that has gotten into the bloodstream and affected the patient's ability to pump blood to the body. This is what makes their blood pressure drop so low. We treat this condition by getting the infection under control and supporting the patient's blood pressure. Signs and symptoms of infection in elderly people. One of the first signs of infection is altered mental status. We all know that, right? That's been drilled into us. A lot of you guys work with the elderly population. You work in nursing homes. You see this all the time, right? If the patient seems off or not themselves, it is worth notifying a healthcare provider to prevent a worse situation. The patient will need to ensure he is drinking plenty of fluids and practicing good hygiene to prevent urinary tract infections. If receiving a PO course of antibiotics, make sure that you teach the patient and their caregiver that they need to take the full course of antibiotics. And of course, watch for any adverse reactions. So that is the end of our shock PowerPoint. We will absolutely be going over all the different shocks on Monday. Management is going to be very important. Being able to recognize what is happening in shock. Why is it happening? Okay. Diagnostics, treatment, evaluation of that treatment. Okay. You just implemented all of these things for your patient. Are they responding correctly? Okay. Education after surviving shock is so important, especially when it comes from sepsis, especially when it comes from dehydration. Especially when it comes to anaphylaxis, right? We need to educate our patient on carrying an EpiPen and staying away from allergens and all the things, okay? I feel like we're probably going to do multiple case studies on Monday because I feel like you guys do really well with case studies, especially after you've studied for a while. And it really helps you think through the whole scenario. And I really love that. So, We are going to, I might as well just go into the emergencies and disasters, and then we can treat all of Monday as a review day. And if you guys don't watch this, it's on you. I don't know what to tell you, okay? Okay. Okay. Nursing management of emergencies and disasters. Dun dun dun. This is, I mean, honestly, this is really terrible when these things happen. I truly cannot imagine being in a situation like this. Um, I know that if I was, that I would act accordingly, but thinking about it, it's really scary. I mean, you think about Katrina, you think about, flash flooding, you think about hurricanes, you think about tornadoes, you think about, avalanches, mudslides. I mean, there's just so many natural disasters, a plane crash, a train crash, a car accident. Um, and when you're talking about triaging patients in and mass patients is it's really heavy and it's really scary. So you have a primary survey versus secondary survey. Okay, we're obviously going to get farther into that. This is going to regard their assessment. Okay, so when we talk about survey, we're talking about a very fast assessment. So primary is going to be A, B, C, D. Okay. Airway, breathing, circulation, disability, exposure. It should be A, B, C, D, E, right? Obviously. So, A, airway. Is there an obstruction or foreign body in the mouth, in the throat? Secretions, is something blocking the airway? Are they bleeding into their airway? Is the head, neck, and spine stable? If they are stable, well, actually, we won't know that if we're dealing with a mass casualty situation or something terrible. So, can you stabilize the head, neck, and spine? Interventions: remove foreign bodies, suction the mouth and nose. Don't forget the nose. Mouth, nose, and throat. So just because you suction the mouth a little bit, sometimes you got to get in there and it's caught back there, okay? Possible intubation: chin lift, jaw thrust. What does this do? This opens the airway. Administering oxygen, of course, monitor O2 with pulse ox. Breathing: does my patient have lung sounds? Is there a tracheal deviation? What does that mean? Why am I looking for a tracheal deviation? Huh? What does it mean? Attention pneumothorax, okay? Chest rise. Is our chest rise equal on both sides? Is it unilateral? Okay? Work of breathing. Is my patient using those accessory muscles and that diaphragm and those shoulders up and down, shoulders up and down? Right? So, interventions depending on the cause. Do we need to ventilate with a bag valve mask if the respiratory rate is low? Do we need a chest tube if the patient has a pneumothorax? Do we need positive pressure ventilation if we have a flail chest? Okay, these are important things. Circulation. Do I have pulses? Do I have a capillary refill? Is my patient bleeding from somewhere? Can I stop that bleeding from somewhere? The skin color and temperature and blood pressure. Interventions, of course, if your patient is bleeding, we want to apply direct pressure on the bleeding sites. Administer IV fluids and blood products if we even have that on hand. CPR, obviously, if your patient is pulseless, right? Disability. This is where we're talking about our neuro status, okay? You got to go back to our GCS. Okay, what is that GCS? If it's less than what number do we need to protect our airway? What number? 8. 8. Because if it's less than 3, our patient is like comatose. Okay, there is no air, there's no function there at that point. Okay, so do we have our pupils equal, round, reactive to light, and accommodation? AVPU. I gotta look that up. Blood glucose. Why? Because that's obviously going to mess with our neuro assessment. AVPU stands for alert, verbal, painful, unresponsive. So, alert, is the patient fully awake and oriented? Verbal, does the patient respond to verbal commands? Painful, the patient responds to painful stimuli such as a pinch or a poke. Unresponsive, the patient does not respond to verbal or painful stimuli. This is a quick and easy way to assess a patient's level of consciousness and determine if they need immediate medical attention. It is commonly used in emergency medical services and first aid. Okay. So interventions frequently reassess the neurostatus for changes. Intubation if the patient is unconscious and unable to protect their airway, and then CT scan to assess for head trauma and injury. And then exposure, assess for wounds, injuries, deformities. Remove all the patient's clothing for a full assessment. Cover with warm blankets to prevent hypothermia. Maintain privacy throughout. So when you're talking about a primary survey, depending on the size of the medical emergency or situation, okay, sometimes this has to be very quick and precise. And then there's other times where you can take time and manage that patient, but also be rushing through it. Okay? Because you could be on the side of the road. You could be in the middle of a hurricane or a flash flood or something crazy, a train derailment, right? So if you're in the middle of a field and a train has just derailed, do you have access to a CT scan? No. Do you have access to a chest tube? Probably not. Do you have access, to all of these things? No. But what can you do in that moment with what you have on hand? Okay? Your secondary survey. This is FGHI. A full set of vitals. Note any changes in those vital signs. And we're also going to include level of consciousness, PERLA, weight. Okay? Give comfort. Try to reassess and allow your patient to rest. Now, I say we can give comfort at any time. Even if you are in the first stage of the primary survey, we are all still humans. We can still look at our patient in their eyes and say, hey, I'm here. I'm here with you. I'm here. I'm trying so hard to save you. I'm not gonna leave you, right? But it is part of that secondary survey for this purpose. And then H is going to be your history and head to toe assessment. In your primary survey, we don't have time for a head to toe assessment, okay? This is after the fact when you have time, okay? So conducting a health history includes that sample, S, signs and symptoms, what brought them in. Allergies, what are they allergic to? Medications, what are they taking at home? P, past medical history, what are their medical conditions? Procedures have they had? Are they a type 1 diabetic? Are they a type 2 diabetic? Do they have congestive heart failure? Do they have a history of AFib? Have they had a spinal fusion? Do they have a history of a AAA? Do they have a history of open heart surgery? Last meal. When was the last time that they had any oral intake? Why? Does this patient need immediate surgical intervention? It's important that we know if they've had a last meal, because why? when we intubate patients for surgery, because of the meds we give them, because of what's happening, there's a huge risk for aspiration. And then events. How did all of this occur? Okay. I stands for inspect posterior surface. So this is where at this point, turn them over, look at their back, look at their butt, look for, and obviously this is occurring last because when are we doing a skin assessment during an emergency situation? We're not, unless that patient has bleeding wounds that we need to stop that bleeding. We are not doing a skin assessment. Okay. All right, so now we're moving on to triage and what that means. So, triage is prioritizing patient care in emergency situations. This is the level of care depends on the severity of the patient's condition. So, I don't know if I feel like most of us have watched Pearl Harbor. It's probably been a really long time. It's at least been a really long time for me, but I remember the scene where the soldiers are being brought into the hospital and the nurse pulls out her red lipstick and she's marking them on their foreheads because this is a mass casualty and she is triaging them with her lipstick that she had in her pocket. Okay. That is Unfortunately, that is the reality of a situation like that where you have mass casualty and huge, horrible emergencies that involve a ton of people. So, red, these are your people that need to be seen right now. Okay, your ABCs are compromised. The patient is unconscious, unable to protect their airway, their respiratory rate is greater than 30, they have no radial pulse, they have a spinal cord injury, major burns, severe bleeding, shock, most likely in this situation, hemorrhagic shock, hypovolemic shock. This could even be like neurogenic shock because of the spinal cord injury, altered level of consciousness, and respiratory trauma like a pneumothorax. Because with a pneumothorax, we need to resolve that. We need a chest tube. If we don't get something in there to try to resolve that pneumo, it's going to turn into a tension pneumothorax, which is then going to lead to respiratory failure and cardiac arrest. So this red, this is impending death if something does not happen immediately. Okay. Yellow, this is delayed. This is the patient that can be seen second. Significant injuries, but the ABCs are currently stable. We have a stable airway. We have stable breathing. We have stable circulation. There is no active bleeding. Okay. And treatment can be delayed for at least 1 hour without significant risk of mortality. Yes, you could have a severe wound with an open fracture, but guess what? They have a tourniquet and they're going to live for the next hour. Do we have open wounds? Yes, but we're not hemorrhaging out of those wounds. Okay, we dress the wound, they can wait for an hour. All right, so that is your yellow. Green, this is your walking wounded. Minimal injuries that are not life threatening. The patient can get up and move. This is maybe they have a laceration to their arm and you have dressed it. They have a laceration to their shin. You've put a dressing on it. They have a sprained wrist. You've splinted it in some way, but they are able to walk around. They are not impending death within the 2 hours, 1 hour, immediate. Okay. And then black is this is really bad. These are injuries that are severe to the point that the patient will not survive. This patient is already dead, or this patient is impending death. Okay, maybe like a blown pupils, where we have signs of brain death. Okay, decorticate or decerebral posturing. The patient obviously is already dead and pulseless. Okay. The increased number of triage levels assists the triage nurse and the physician. There is something called the START method, the emergency severity index, and then there are other procedures defined by the United States to assist the nurses in assessment process after a primary and secondary survey, are main ways for the nurse to assess the patient. So this is a very common way, and the most recognized way to triage patients in this type of situation. So, going more into triage, we have the START method. This stands for simple triage and rapid treatment. So this allows triage of patients in less than 30 seconds based on 3 observations. And you want to check them, in order. That's very important. So number 1, breathing. Number 2, circulation. Number 3, mental status. Is the patient walking? Yes, you get a green tag. If the patient is unable to walk, are they breathing? Yes. Respiratory rate greater than 30, red tag. Respiratory rate less than 30, check circulation. Are they breathing? No. Do they need repositioned? And then they start breathing? Red tag. If you reposition the airway and they don't start breathing, black tag. I know it sounds really scary when you put it that way, but if you're truly in a situation like this and you need to triage patients really fast, you have to make life or death decisions within that 30 seconds. And it's really scary and hard to talk about or even imagine, but this is so true for these situations. So next, 2, is their circulation. Do I have a radial pulse present? And how is my mental status? Okay. If my radial pulse is not present, red tag. What does red tag mean? These patients need to be seen immediately. And then 3, what is the mental status? Can they obey commands? Yes. Okay, yellow tag. They cannot obey commands? Red tag. Okay. Is this making sense? Because I do need you guys to be able to go through this process and evaluate whether this patient is going to need immediate intervention. Do they need intervention after 1 hour? Do they need no intervention, or, green tag walking wounded intervention? Or are they too far gone where they receive that black tag? Um, the emergency severity index. So, level 1 is resuscitation. This is the patient that requires immediate life-saving intervention. This is cardiac arrest, prolonged seizures, and then shock. So this is an unstable patient that must be seen within, immediately. Immediately. So level 2 is emergent. This is emergent and time sensitive and must be seen within 10 minutes. This is a patient that is experiencing stridor. What is stridor? Stridor is when your airway is constricted, and if you think about your airway as like a straw and someone is squeezing on that straw, the smaller the straw gets, the harder it is for air to pass through. So this could even be happening to a patient that is going into anaphylaxis, where their airway is swelling and swelling and swelling. They're going to become more and more stridorous. A patient that is experiencing chest pain, possible MI, or a stroke, this patient needs to be seen within 10 minutes. Level 3, I like that with the emergency severity index and the triage, both level yellow is within 1 hour. So I like that you're not going to get confused. Like, oh, well, one of these yellows is 30 minutes, but the other yellow is 1 hour. They're both 1 hour, which is really nice. So, level 3, the patient must be seen within about an hour. You have vomiting, abdominal pain, maybe a hip fracture. Why is hip fracture on there? We have to think about circulation. If a hip fracture is dislocated for a long period of time, for greater than an hour, you could have a pulseless limb, which is a medical emergency. You could have clotting, which obviously is going to put that patient at higher risk for a stroke, DVT, PE, MI. So that's why a hip fracture is on there. And then level 4 is less urgent. This is potentially serious but can be delayed. So back pain, cystitis, rash. And then level 5 can absolutely be delayed. This is vaccination, sore throat, prescriptions refill. I mean, this is very much non-emergent. Triage duties of the RN in the ED. So if you are that triage nurse in the emergency room, you are looking for, why is my patient here? What is their complaint of illness or injury? The level of pain, level of consciousness, the circumstances, what happened? Where did they come from? What time did this happen? The treatment of injury or illness prior to the ED. What happened at the scene? Okay. Was the patient intubated on arrival at the scene? Was the patient intubated en route, on the way? What medications or emergency treatment did they receive at the time of injury? The method of arrival to the ED. Were they dragged into the emergency department? Were they thrown out of a car and left right outside of the ED parking lot? Did a ambulance bring the patient? Did their friend or mother or brother rush them to the ER? How did they get there? The physician or health practitioner needs to see this patient at some point, and that depends on triage. The health status prior to injury or illness, history of medical illness and previous surgery, those go hand in hand. Previous hospitalizations go hand in hand, because what was wrong with them before? Do they have a history of AFib? Do they have a history of type 1 diabetes, type 2 diabetes, heart failure, a CABG, GI bleeding? What was going on before this incident? Allergies, including medications, eggs, latex, nuts, etc. So those big allergies that we need to know of immediately. Current medications, use of recreational drugs. Why? If this patient was just doing a bunch of cocaine, we probably need to know that, because that's going to change our treatment when it comes to beta blockers, vasopressors. It's important to know for dysrhythmias or things like that. Smoking history, evaluation of immunizations or currency for tetanus. What happens if you haven't had a previous tetanus shot within the last 10 years? You can go into tetany, which is life-threatening. That is so important. If we don't know, especially in an emergency situation, if we don't know your immunization history or your tetanus history, you're just getting a tetanus shot right then and there, because we would rather or not over medicate, but give it to you when you don't necessarily need it, instead of you actually going into tetany. And then a brief assessment of body systems, including behavioral health screening for depression or suicidal ideation. Your last menstrual period. What if the patient needs CT, MRI, surgery, something impending right then and there, and she's pregnant? time of last meal or oral intake, we already talked about this. What if the patient needs surgical intervention? It's very important. Focused assessment on system involved with presenting complaint. This is imperative. I mean, and depending on the system involved and the severity of that involvement, this could very well be at the top of the list. And then special circumstances or request of patient, especially those related to limitations regarding treatments, as in a DNR or Jehovah's Witness. Caring for life-threatening conditions. When we're talking about airway obstruction, we want to discuss partial versus total obstruction. So, is there a foreign body or secretions that are blocking that airway, or is there something totally obstructing that airway, like anaphylactic shock that has completely closed off the airway? What is the cause? Okay, signs and symptoms, management, which is establishing that airway. Do you have an oral pharyngeal airway, which is which a lot of people just refer to as an oral airway, and it is a little device that you can just put in the mouth that stops the tongue from flopping back and blocking the airway. In endotracheal intubation, maintaining the airway. I talked to you guys about my worst fear, anaphylaxis, and having to do an emergency tracheostomy in the field, a crike. Okay, this happens. This can happen. And then looking at hemorrhage, loss of fluid volume is going to equal fluid volume deficit, which equals decreased cardiac output. You guys have heard me say this 100 times, okay? If you have decreased cardiac output, you have decreased blood pressure, you are hypotensive, your tissues are not perfusing, your brain, your lungs, your heart, your kidneys, your bowels, your stomach, your extremities, nothing is perfusing, okay? You have a decreased lack of oxygenation. This is impending death. So we want to prevent hypovolemic shock. That is the goal. We need to stop the hemorrhage. We need direct, firm pressure to the site, immobilize the extremity if, say it is a femur fracture. We want to immobilize that extremity as fast as possible. We want to put a tourniquet on that extremity as fast as possible. Decrease that bleeding as fast as you possibly can. And then, are we in a situation where we can replace fluids? I hope so. For blood products and fluid replacement, we want to get an isotonic fluid in them as fast as possible. Okay, LR, normal saline, ASAP. Females younger than 50, O negative, and then O positive for all others. Disaster nursing and MASH. Oh my goodness, my mouth is dry. It's getting late and my brain is farting out. Okay, so this is the mass casualty incidence, MCI. The Joint Commission has come up with this. This is our emergency preparedness plan. Every hospital system has an emergency preparedness plan. It's not talked about a lot. The training isn't really there for hospital staff, but if something like this occurs, your leadership, administrators within that hospital have a plan. Okay, the notification is going to go out. Disaster tags are going to be there with your triage priority, your red, your yellow, your green. ID info, treatments, meds given. All of that stuff is going to go on that disaster tag. Obviously, the goal is the greatest good for the greatest number of people. Now, this is where it gets really scary and really sad. The more people that are in this mass casualty, the quicker and more decisive the medical staff have to be between that red tag and black tag. The faster it has to happen. And unfortunately, you can't save everyone, and you have to save the greatest number of humans. If there were less people, you could probably have more assets into treating those people that are borderline black and red. And that gets scary and really sad if you really think about it. So, nursing duties are going to be managing entrances, communication with the family, performing duties probably outside of your scope of practice, and absolute ethical dilemmas, especially when we're talking about that red tag, black tag, women, young men, children. It can be really, really scary and sad. So, natural disasters, the casualties and life lost is usually trauma related. It's usually from huge wounds and hemorrhages, drowning, blunt, trauma, impalement, exposure to natural elements. I can't even talk anymore. We're going to discuss more scenarios on Monday. Food, water, and shelter issues. When you have a lot of water that isn't clean, you're talking about waterborne infectious agents, and waste removal could be contaminating your water sources, especially if there's breaks in the ground, in the piping, in the septic systems. So ensuring that people have clean water is so, so, so important. And this is where the National Guard and the Red Cross and all of these big organizations go out and hopefully help the survivors and their families. Poisons. So when it comes to poisons, we of course have the poison helpline. A lot of us that have children, you've probably caused or called the poison helpline at least once. I know I have called them one time because I had a magnesium lotion and Henry tried to eat it. So I had to call the poison helpline to make sure that my kid wasn't going to have anything terrible happen because of this. So when someone is exposed to a poison, you want to assess their airway, ventilation, and oxygenation, and make sure that the air that they're breathing, they're removed from that toxin. We want to call poison control as soon as possible because they are going to know exactly what to do for whatever that toxin is. You really want to know what is that substance, how much did they get, when did it happen, the signs and symptoms of what that patient is experiencing. Did they swallow it, and did it cause burning of their mouth? If something is like really acidic, like say they swallowed bleach or something like that, is there evidence of burning within the mouth? Do they have the ability to swallow? What is the age, weight of the patient, and pertinent health history? We need to remove the toxin. Gastric lavage, that is literally like putting water or something within the stomach and then forcing it out. So like rinsing it out big time. Syrup of ipecac, this is going to force vomiting. Cathartics, I gotta look that up, make sure I give you the right term. Cathartics are medications that promote bowel movements by increasing intestinal motility and fluid secretion. So if that was ingested, first we're going to start with gastric lavage to try to get it out of the body by rinsing. Syrup of ipecac is going to induce vomiting, and then cathartics are going to help remove whatever is in the bowels to help get the poison out. Decrease absorption. Milk can help with corrosive substances. Milk is a natural base. I mean, think about how neutral, well, how alkalotic milk is. Activated charcoal can be used for antidote for a lot of things, a lot of medications, diuresis and hemodialysis. Hemodialysis, of course, because it can remove toxins from the blood. And that is the end. That is it. So I'm really glad that I had a chance to do this. This saves us a lot of time. I mean, saves us over an hour. And if we were actually in class and actually having discussion through the case studies and stuff, I don't know if we would have actually gotten through this and been able to review anything. So, please, I mean, obviously, if you've gotten this far, then you watched it, but please watch this. Please take notes, because I will not be going over these PowerPoints on Monday. This is your lecture right here, right now. This is your lecture, for the rest of shock and for, trauma and triage and recognizing medical emergencies and all of those things. So Monday is going to be a review. We're going to do case studies. Please expect more emails from me this weekend. Okay? Email me if you need anything. I'm here for you. And I will see you Monday morning. Okay? Bye, guys.